Right. Well, thanks everyone for joining us today for this August issue of the LAA Journal Club. We have Mike Palmer, one of our HEMS paramedics, who's going to lead the critical appraisal today, and we're privileged to have with us the two of the authors from the paper. The lead author, Joe Griggs from KSS, and a former LAA and / KSS colleague, Ewout, who's also joining us from the Netherlands, to one of the other authors to comment on this. So I'll turn this over to Mike now and let him get started with a review of the paper.
Brilliant. Thank you, Mike, and thanks for the introduction. I want to say back to you, Mike, thank you for allowing me to do this today. And a little bit of a sad goodbye, I think, really. This is probably going to be one of your last journal clubs before you move back to Canada. So thank you for that. If you're new to LA Journal Club, please go to the YouTube channel, subscribe to feel a bit like an influencer. But yeah, there's lots of other kind of papers there on there. So please go back and review and even kind of re-listen to this one again. And yeah, thank you for Joe and Ewout joining here today. So going on to the paper, as you may know already, so Helicopter Emergency Medical Service dispatch in older trauma, time to reconsider the trigger, by Griggs et al. And thank you again for Joe and Ewout for joining us today. A mixture of doctor, paramedics, nice to see, and also governance leads from KSS. And it's a paper that was launched back in 2021 this year. So before we go into the paper, a little bit of background of KSS. They, being a single service paper, KSS approximately attend about 1,600 patients a year. And in comparison with LAA, I think our latest kind of 2021 figures, we as LAA, we went to about just under 1,500 patients. Square kilometers, 7,390 square kilometers, and in Greater London is roughly about 1,500. So a vast rural kind of coastline, coastline, rural farm towns, cities as well. 2 helicopters based. I'm not too sure, this was over a 6-year period, so I'm not sure whether they had 2 helicopters running both at the same time, but I primarily normally a non-medical dispatcher, but we can talk about that later in the PowerPoint. And that's based down in Coxheath in Kent. And that's going back to my roots, as you probably some of you might not know, that I was a call taker down in Coxheath way before I started my career as an ambulance clinician, but that's kind of my roots started down there in Kent. Normally they go to medical and trauma calls. However, this paper today is obviously looking just at trauma. Single doctor, single paramedic crew, and they've got the 2 aircrafts of the MG 902 and the 1669 as well. So the introduction really, before going into the paper, as we may probably all know already, that major trauma is being regarded as a disease, particularly in the young, particularly in males. It's also been defined as the leading cause of death and disability of under the age of 40 years old. But more importantly today, really, we're talking about this term, the kind of silver trauma. So trauma, with trauma in the elderly population over the age of 65, and it's increasingly been documented that it's a significant challenge to healthcare and systems. With advances of modern medical care, there's an increasing population of older patients with the possible injury. And just kind of skim past on that, older trauma now accounts to 50% of cases entered into the TARN database. And those patients over the age of 65 tend to do worse when you match the injury severity score, so the ISS. And what I've kind of been researched through TARN is that at the age of 65, your average life expectancy is 18 years for males, and further 20 years for females. And then by the year 2030, there's a projected increase of 50% of people over the age of 65, and then 100% over the age of 85. So what I'm kind of gathering here is that there's an increasing aging of our population. And this is not going to go away, or probably it's going to get more of an issue. Older patients have fewer surgical operations, less likely to be transferred to a major trauma centre, and it's more likely to die following serious injury. So that's kind of like an introduction really of kind of why my thoughts really of why this kind of paper was set out there, really to kind of find these patients a lot earlier than we can at the moment. So yeah, going back to the paper, as already described, and the methods of how it all kind of came about. So the method was a single service, so just KSS. It was a retrospective cohort study over a 6-year period. And this was from 2013 to 2019. They included 1,321 patients over the age of 65 with an interquartile range of 69 to 89. Everything was recorded on the HEMS base, and there was both, interestingly, a critical care paramedic and also a non-clinical HEMS dispatcher dispatching to these teams. They had 3 types of dispatch criteria, exactly the same as we have in London. So you have the immediates, interrogation, and crew requests. Just for people who don't know, immediates in London, we have 7 criteria of 1-unders, fall from heights, amputation request, trapped, ejected from a vehicle, and death in the compartment. That's our immediates. That's 3 minutes. Interrogation, that's when the caller, or the call taker rather, would ask further kind of clinical questions to decide whether they need to send the aircraft or not, or the enhanced care team. And then crew request is when we really rely on clinicians giving a report and whether we need those enhanced care teams there. So that's the 3 dispatch criteria they looked at. They also looked at the injury sustained in that population, the enhanced interventions performed by the critical care team, and also then the last final hospital dispositions. So whether they went to an MTC, a local trauma unit, or a local ED rather, and then a local trauma unit. So what do they find? What were the results? So straight down to it, if I'm honest. So essentially they recruited 6,989 patients over that six-year period. However, they removed 567 patients because they were under the age of 65. And then they also removed a further 17 from missing data, and also no injury was documented on 70 of them. Also, we sometimes, it might be either Thames Valley or London, but mutual aid, that wasn't included as well. So sometimes we help out with a border on jobs. So 13 was removed from there, and then 1 was inter-facility transfer. This concluded that a total patients over that 6-year period of 1,321 patients, and they broke them down into these 3 dispatch criteria of immediates, 423. That was roughly 32% of the calls. Interrogation, 575, which is 43%, and the crew request was roughly about a quarter of the calls at 24%. It's a really, really good descriptive paper with lots of tables that we're going to go into now, with the demographics, the mechanism, the presentation, and the enhanced clinical interventions they performed. Going with the immediate interrogation crew request, even though I said about our timings for London, it was very kind of matched, quite similar to what they found in the paper. So their immediate calls, they took 6 minutes to send the team. And then for interrogation, it was 15 minutes. And then the crew request was 37 minutes. And also just to add as well that 62% of the population of the 1,321 were males. So going straight down into the results, essentially the main results that I kind of got from the paper is that the main injuries that they were sustained were head injuries. That was 67%. That was the most kind of injuries of identified, and also further there was thorax injuries as well, which was 41%. There's loads of information on this table, but what kind of was really quite interesting is when they kind of looked at the mechanism. So the larger amounts, most common were falls for greater than 2 meters, and also drivers of RTCs. However, when you kind of delve deeper into the immediate interrogation or crew request, it slightly changed. So with the mechanism of injury for the immediate dispatch was greater falls of 2 meters and pedestrian involved in an RTC. The immediate dispatch criteria, that was drivers of an RTC. And then for crew request, the most significant one was falls of less than 2 meters. So how I kind of read that really is that essentially that in the immediate and the interrogation, we weren't finding the falls of less than two meters. So that was what I found quite interesting. Going on to the next slide with the clinical interventions that they performed. So PS, so pre-hospital emergency anesthesia, so RSI, they performed that 26% on crew request. Interrogation was 14%, and also immediate was 22%. Blood products, normally traumatic cardiac arrest and greater fall from heights were more in the immediate, and they gave more blood on the immediate, say, of 12%. Interrogation 5%, and crew request was 4%. Triage and MTC, that kind of like flipped on its head as well in this time, so similar to an RSI, so pre-hospital emergency anesthesia, how they called it in the paper. Crew request went to an MTC at 70% of the time. Immediate was 57, and interrogation was 56. And just a side note that ketamine and hypertonic saline was similarly administered across all dispatch groups. So going into critical appraisal, I used the CASP checklist. So there's the cohort study checklist using the clinical appraisal skills program. So going into the first question, so did the study clearly address the focus issue? Well, definitely yes. They clearly explained the introduction, the title, so that was quite straightforward for me. The next question, was the cohorted recruited in an acceptable way? Yes, they were. However, even though there was a total patients of 6,989 patients and they attended 1,321 patients, there was no discussion of any kind of missed cases. But this would have been a massive undertaking from KSS, from CCAM, the local ambulance service, and their follow-up. As described in the paper, that they only attended the HEMS patients, which is called dial 999. However, the total 999 calls for the ambulance service for the elderly is a quite large kind of number. As already mentioned, that this was a retrospective data collection, and it relied on the clinicians inputting the data onto the HEMS base. So next question, was the exposure accurately measured to minimize bias? Yes, it was. A total said 6,989 patients. A further just at 5,500 removed for not being over the age of 65, and the further of 87 moved because of missing data, 13 mutual aid, and 1 was a secondary transfer. So that was seen quite clear for me on the outlook. Was the outcome accurately measured to minimize bias? Yes, I think it was, as long as all the clinicians entered HEMS space was accurately entered. So I thought, was that all correct? Mike, you got your hand up. Hiya.
I'll let you finish if you have anything else to say about this one, then I'll jump in just for a question.
With the fourth one.
Yeah, just around outcomes.
Yeah, so I think I'll be going into more of the outcomes on the next kind of couple of questions. So maybe hold that thought, or do you want to ask that question now?
No, we'll come back to it later then.
Cool, nice. So the next slide. So have the authors identified all the important co-founding factors, and then also in relation to that, on the next be questions, have they taken into account the cofactor factors of design and the analysis? So what I was thinking about this was I really couldn't really kind of tell, just because one of the examples I was thinking of is that this paper that came out roughly in the same period, and essentially, without going into too much detail of this paper, another paper done by KSS, and it was a novel method of non-clinical dispatch is associated with a higher rate of critical helicopter emergency medical service interventions. And they concluded, so during the 6-year period of our original paper that we're discussing today, they published this paper, and essentially during a period of April 2014 to April 2015, they had a paramedic-led dispatch. And then further the next kind of year periods from April 2016 to April 2017, they had a non-medical dispatcher. So what really concluded that a non-medical HEMS dispatch aided by a bespoke algorithm improved accuracy of HEMS tasking. But what I was thinking that really essentially, they had this paper released and then it didn't really seem quite clear that during the 6-year periods that they didn't have the same amount of dispatch or the same type of clinical experience or any clinical experience as well. So I was interested to see whether that might have had an effect on something as well, especially if they had that 1-year period of just a paramedic-led dispatch, and then the next year period it wasn't. Therefore, this data collection during these 2 periods in the dispatch paper both did say that there was a CCP and then also a non-medical dispatcher. And I'm also aware that these non-medical dispatchers currently with KSS do sit with a CCP, which sometimes might have some influence. And then also this paper kind of did say that in 2016, due to rota restraints and the availability of HEMS paramedics, they were no longer on any dispatch desk. So what I'm trying to say is that during this 6-year period, there might not be that same consistency, which might have changed the kind of dispatch and with the interrogation methods. So just a thought.
Mike,
Go on.
Yeah, just because it's we always talk about it's easy to point out potential faults. Have you thought about, if you were to or involved in redoing this paper, or you're doing a paper similar yourself, how you could address that issue of having the change in dispatch methods during your time frame, how you would address that in the paper so it was clearer to the audience or could help interpret the data better? Did you have any thoughts about what to do?
Well, just so I kind of go on later on in the presentation regarding kind of my thoughts about going forwards, and I kind of open up this kind of the similar paper with regarding a HEMS paramedic dispatch model, either with other services as well, but making it quite clear whether who's going to be in control and who's kind of leading that interrogation progress. Is that what you mean?
Kind of. So I think if we're just reporting in the paper, if there had been sort of a time scale and it showed the different periods and a comparison between the 2 different periods, because we don't know whether or not one of the things we couldn't tell from the paper when you looked at it was whether or not all of the crew requests occurred maybe in the second half of their collection period, where they didn't have a clinical clinician in dispatch, as opposed to the first half, or were they evenly distributed across the time frame. So something that showed the time when the dispatch models changed in the paper, and then showing the distribution of the different types of calls over that period, or analysis by year across it to see if there's any change, something like that, or the two periods would have helped just ensure there was no bias from that or confounding from that change in the dispatch model that occurred. I think that would be the one simple thing to simple thing to do, not so simple.
Yeah, that's it, definitely. And even looking at this paper as well, during that year period, I think they had, looking now, the paramedics dispatched on 2,510 patients, and then a non-clinical dispatch on 2,184. So it's just interesting that they had that full year and then the next year it wasn't, and it wasn't that clear in the paper when it was. So yeah, no, you're right there, Mike. But yeah, thank you. So was the follow-up subjects complete enough? Well, if I'm honest, I can't tell. We didn't, during the whole design of the paper being a retrospective paper, they didn't have any follow-up. And the only really kind of follow-up they had was, I know that on the immediate dispatch process, that's had the highest rate of PLE. But again, it's really quite difficult, really, that we're assuming that all the enhanced clinical interventions that we do is what the patient needed. And sometimes, as we all know, we kind of discuss in D&D all the time regarding whether we should have done an RSI or not, and whether it was right for the patient. And so there's no real kind of patient orientated outcomes as such. So that was kind of, I thought it would have been good to have, but again, there was a lot more work to kind of find that out. And then, yeah, it didn't conclude that there was no kind of long-term follow-up on mortality. So I think I've gone through the results already, but please feel free at the end to let me skip back to that table that kind of listed all kind of the massive amount of data that they all collected. How precise were the results? So there's lots of things to consider in that table, and yes, essentially I do believe the results. The fact that it was a retrospective cohort without any comparison groups, so it's not that possible to measure, as I said, about the benefit and outcomes, etc. We're still running trials on blood, for example, and we don't know. We all like to think that these procedures that we're doing pre-hospital are the right thing to do, but it's still, it could be, it's simply a descriptive kind of study, and it could be kind of hypothesis generating. And then essentially kind of looking back at any further studies, this is one paper that LAA did publish a number of years ago now. They didn't look at silver trauma. However, they looked at cause over a 3-year period, and they looked at the dispatch methods only, and essentially very similar to this paper, that they found that interrogation, crew request was more accurate than mechanism of injury. And it kind of really confirms for me, really, that these dispatch algorithms are really complicated, and even more so I can imagine, I can think now in the elderly. And also going back to what they were saying regarding the falls from less than 2 meters being in the crew request. This was pulled from Tarn back in 2017, and essentially on the table on the left shows the changes with age, and essentially low falls become such a more common cause of major trauma. So falls of less than 2 meters, and the most common injury now within the Tarn database. It should be noted that the patients with single fractures distally to the elbow or knee, or isolated neck and femur fractures, are not included in the Tarn, even if they stayed longer than 3 days in hospital. But essentially the inclusion of these injuries would increase the patient suffering from injuries from less than 2 meters. And also the table on the left, time to CT, with time to head scan of all the patients with traumatic brain injury, Tarn have stated that it takes 1.5 hours longer. This might be due to difficulties of early identification, difficulties of head injury assessment, patients with dementia, higher proportion of acute or chronic subdural bleeds, or minor mechanism, and then slower presentation, really, due to the older cranium being more space to accommodate some of the bleed in the older patients. So what I'm saying really is that essentially this paper found these low acuity falls, and then essentially that they provided like a pre-hospital anesthesia, and this is kind of like the trend that I'm kind of seeing from the Trauma and Audit Research Network. So can these results apply to the local population? Well, yes, as I just explained from Tarn, there does seem to be a delay getting to these patients. And does the results fit to the other available evidence? Well, it hasn't really been much kind of data out there apart from, what I've noticed from Tarn, regarding the paper from LAA as well about immediate interrogation and crew requests. But I'd like to think, going back to Mike's comment as well regarding, we want to make sure that this paper could be done again with the single model of a paramedic dispatch or a single model of a non-medical dispatcher, and then other services as well. So, with links to NOTS, for example, EHAT, that will be really quite interesting to see. Important. What are the implications of the study of our practice? Well, I think what I've kind of concluded really, and kind of what's kind of helped me with my kind of practice really, that older patients sustain a large injury burden from a relatively low mechanism. For example, these falls less than 2 meters, which don't really fulfill the HEMS immediate dispatch criteria, and they're not really being found in the interrogation process. Clinicians or non-medical dispatchers should be aware of this silver trauma, really, I feel. And the sensitivity of dispatch should be kind of slightly kind of nuanced, and then getting getting the enhanced teams there as quickly as possible. This paper shows the delivery of interventions with no patient follow-up, and as I said earlier, that we know that we'd like to think that pre-hospital anesthesia does help our patient and improves outcomes, but that's not really clear as well. And did the RSI actually really kind of benefit, for example, the patients? For example, this kind of opens up to bias some subjective kind of decision for critical care teams. I don't know if the crews have been called, the team for an RSI, did they feel more compelled to do it? I hope not, but potentially that they might feel that might be more compelled to do that. So moving on, really, kind of the bottom line really is that kind of one of the reasons why I kind of invited the wider LAS group here today is that we really rely on crew requests here in London and nationwide, really. And if we don't rely on those crew requests, sometimes these probably patients might slip through the net, as we've seen. And then a large proportion of these kind of silver trauma patients do require an MTC and a pre-hospital anaesthetic. Creating a dispatch algorithm is extremely difficult for older patients, and the level of under triage by relying on mechanism of injury. And as I said already, we might need to kind of lower our thresholds for dispatch. As I said, early reports are essential, and the ambulance clinicians play a big part in all this and in the decision making of delivery of enhanced care. And as I said already, the published by Tarn, falls with less than 2 meters, the most common mechanism of injury in older patients. And this, delay of what we found of early identification could result in treatment delays. So here are my references, and I feel like I kind of whizzed through that. But any questions, any thoughts?
Thanks, Mike. That was a really nice, clear, and well presented review of the paper. It was a great job. I was a little nervous at the beginning with your introduction that I appreciate the fond farewell. I thought you were going to link me to silver trauma instead, which would have been less appealing. But anyways, so I think that's there's a few good take-home messages from that. I think the one of the key things I think you said, and I'm sure there'll be a little bit of debate. I'll come to Tom for his thoughts on this in a few minutes, but it's that whole link of without actual hard outcome measures and longer term outcomes, it is a little bit hard to correlate simply interventions with the benefit, and also that in these patients, whether some of the benefits for these interventions are the same as we would anticipate in a younger population or different population. And then also there's other debates about the management of silver trauma and social factors and things that go along with that. So there's a whole number of different things that fit into this. I do think one of the key things is messages for the crews, as you mentioned, is not just that not just that we might look to them for crew requests, but if HEMS is responding and they're getting that call for updates and they have an elderly patient, to be a little more cautious, I think, standing us down, because then we're behind the curve. And sometimes it's not always as easy to appreciate the burden of trauma that a patient's had when they're elderly. And I've personally seen that recently, where a team was stood down and then retasked to the patient when they recognized that actually, although the mechanism at first didn't look that bad, the realized the patient was actually quite traumatized and was an elderly patient. So we'll give first offer for comment to Joe and Ewout, and I'd be curious to hear just your general thoughts, but in particular, is there anything else about the paper that your experience of doing the paper that you learned that you thought wasn't captured necessarily in the paper you'd like to share? And then also how you've used this in the service has it informed or changed your practice at all? Or are you looking to use it to do that? So why don't we give Jo first comment, since she's first author, and then we'll go to Ewout.
Hi, Mike. Thank you both for inviting us. Firstly, yeah, it's great to be here, and thanks for your appraisal. It's quite a healthy thing to do, so hopefully we can do a bit more of it. I think, yeah, it's the elephant in the room, isn't it? I think you've captured a couple of points there, which certainly, yeah, looking back at it, I think we would like to have had, certainly around some of the physiology of the patients, and certainly some of the outcome data. I think at the point of kind of bringing this paper together, we kind of discussed at the time, but we wanted to keep the aim more around looking at our sort of dispatch mechanisms and things here. So I think one of the other things you said, Mike, was around the changes that we perhaps have implicated since writing the paper. And I think generally it came about as a group of clinicians, as we all are, sitting in a room and just anecdotally thinking, you know, we're attending a lot more older trauma patients. We kind of had knowledge of the TARN report, and we were just kind of keen to see what our data or what our numbers were really telling us, and whether that was actually brought out in the numbers. So it was quite good for us to kind of see the percentages that we did find. And I think for us, one of the big things is perhaps there's been a slight lag between the type of patients that we were seeing as HEMS teams and our sort of dispatch criteria that we were using. So one of the key things that has and will come out of it, it's being drafted now, is a review of our dispatch mechanisms and dispatch criteria specifically. So it's a tricky one, as you've kind of alluded to. I think what we very cautious of, and it's a very expensive operation which we all run, and I think there's hesitation around making sharp changes on not a solid evidence base. But I think if we can kind of use a cautious approach and certainly start to look at some of the smaller steps, such as the RTCs at slightly a lower speed perhaps for older trauma patients, that might be a start. And I think the other, I'll just make one other point. I don't want you to kind of chip in on it, but certainly what we're also thinking about is just not so much changing dispatch criteria, but also finding ways to get more information into that call handling stage. So obviously we dispatch currently with as you say, a non-clinical dispatcher. We have clinical input from our CCPs, who either most frequently co-locate at the dispatch centre, but sometimes they don't. And one of those things is around using sort of video footage from scene, which we're kind of exploring, as yourselves. So I think there's certainly lots more work to do, but I think it's all quite hopeful and going in the right direction.
That's great. Thanks, Jo. Ewout, your thoughts?
Yeah, thank you very much, Mike, for a very thorough review of the paper. One of the main points I really like that you touched in your review was the different dispatch systems used during the period of analysis, during the 6-year period. And I think one of the things we could have done and haven't done in the paper is, as Mike already pointed out, is a sensitivity analysis with a subgroup of patients that were dispatched by clinical dispatch compared to the non-clinical dispatch to see if that makes a difference. Because now the whole discussion in the paper is more focused on dispatch criteria and improving ways of gaining more information around a set dispatch system. But I think it would be really valuable to repeat a similar kind of paper in a dispatch system that has clinical dispatch to see how that affects the number of crew requests, and within the group of crew requests, how many patients require advanced interventions. And touching on that, I think it's a universal problem of pre-hospital research what you choose as your endpoint. Because I agree that pre-hospital interventions may not be the endpoint we're actually looking for, because who says that the patient actually needed those interventions or benefited from those interventions? But if you look further down the line and you look at mortality or long-term outcomes as we can obtain from TARN, those are also influenced not only by our pre-hospital interventions, but also by in-hospital interventions and interventions further down the line. So we have to find something in the middle, which is quite hard, I think, and we might want to look at more patient centered outcomes in the future when we are able to collect those. And I think for that reason, it's really important to establish relationships with hospitals so we can get better follow-up of our patients. And that is some of the things I took from my secondment with LAA, where there's a good follow-up system in place to follow patients and actually see not only how they're doing physically, but also maybe how they are able to pick up their daily activities and get a meaningful life again after their accident. So I think there are two things we can learn and adopt in different services. And Mike already touched that one of the things we could take from this paper is that we could nuance the sensitivity of our dispatch, maybe for the elderly trauma. But I think that is easier said than done. In the paper, we mentioned some examples as nuancing sensitivity for example, the speed of an RTC for elderly dispatch, or nuancing clinical cutoff criteria for example, vital parameters. But there is no evidence yet for what we should choose then as an alternative in this group, and we might have to go with trial and error to see how that improves. But that will be small steps at a time, unless someone else has a suggestion how we can derive more evidence-based criteria for this group.
Thanks, Ewout. Just to comment on that quickly, then I'll get Joe back in. I agree. I think outcomes are one of the main things that we really need to start to look at in pre-hospital care, and that's one of those things that I think should be a joint project with multiple services, starting to come up with a common outcome set and starting to look at ways to do that for pre-hospital studies, and using that so you can then start to combine data and compare them and whatnot between different services. But even just coming to some agreement as to which are the beneficial and important ones. I know KSS and Richard and Joe and yourself have been actually leaders even starting to do that with the idea of using interventions and stuff and trying to find ways. So you're forging ground to do that. Joe, your comments, and then we'll open up to the rest of the group.
Yeah, probably just to pick up on what's sort of been mentioned, but I think just as a service, I think what this paper and perhaps a couple others that were running at the same time have brought out is being able to kind of develop that strong collaboration with the ambulance service. And just a nod to Jack Barrett. So his work, his PhD work, will look a little bit more around sort of the paramedic decision making and how to identify the important clinical signs and where we bring frailty and other comorbidities into some of that early decision making on scenes where it means that we are activated that bit earlier. And I think from our geographical standpoint, obviously with perhaps a 30-minute kind of launch to scene time, that's where some of those timelines can be shortened. So, and glaringly, the thing that was probably missed, but knowingly missed on this paper was those patients that we don't actually see. So those patients that the ambulance service attend to, either whether it's by geography, they're close to an MTC, or they go into a trauma unit, and those weren't picked up in this data. So I think they're just, certainly from a methodological point of view, bringing some of those things out will take a bit more time, but I think hopefully we've kind of alerted the reader to the fact that we're aware that those things weren't quite addressed here. But yeah, work to do.
Yeah, thanks, Joe. And I think Mike kindly sort of gently touched on that point in his where all patients included. Mike, actually, do you mind just stopping your screen sharing, then we can see everyone's faces and let Tom comment now. Go ahead, Tom.
Thanks very much. Really good discussion. Nice to see everyone. So I guess two comments from me, or two areas of comment. One around this discussion about what we should be looking for in papers in terms of what outcome. And I guess I'm minded of the two. There's been a couple of papers recently from Wales and Scotland looking at case control methodology, looking at the impact of their services on patients' mortality, which seem to be positive in both cases. It'd be really interesting to see that work repeated in less rural systems. I don't think we're in pre-hospital care necessarily always going to be able to use patient outcome measures in a meaningful way in studies, because the differences aren't going to be big. We have to be honest and say, even if we're convinced what we do is right, and even if there's some evidence that we are improving outcomes, the majority of patients that we attend will have the outcome they're going to have irrespective of the pre-hospital care. We're such a small part of a big long sort of chain of survival that trying to hang our hat on mortality every single time we do a piece of work, I think is going to send us round and round in circles. See the intensive care unit literature, most of which is similar. So I think there is something about accepting process, meaningful process measures as part of our research. But I think, as Mike alluded to, I think it was patient reported outcome measures as well. Are these patients experiencing the service they want to experience? Are they getting the analgesia, sedation, and humanitarian care that they need? Are they being taken to the sort of centres where they and their family feel they're getting the right care? So I think that's all useful. There's a general point that I always make about silver trauma, which is I think there's two bits to it, and I think we need to start to distinguish them. There are the older, over 65, but relatively well active patients, the people who are hang gliding in their retirement, who are not the same as the 85-year-old multiply comorbid frail patients who get a very high injury severity score falling from standing, but basically have a whole load of fragility fractures. And TARN is odd because it kind of excluded neck of femur fractures right from the get-go, recognizing that was the kind of archetypal fragility fracture, and that's not major trauma. We're not interested in that. But actually, as the trauma systems have matured and we're starting to capture all of these patients, and then we're going, oh, but look at all these rib fractures and look at these vertebral process fractures and look at this and this, these patients acquire an injury severity score that puts them into a polytrauma, a major trauma bracket. And I'm not sure we've completely designed a system that's fit for purpose for patients with those injuries, because they come to major trauma centres where they're consistently pipped to the operating theatre by younger patients needing damage control surgery, whereas when they have an isolated neck of femur, they go on a neck of femur pathway, which has a separately commissioned operating theatre and different standards. So I'm always, when we talk about silver trauma, keen to just kind of pull it apart a little bit into those frailty and non-frailty bits. And I hope in 10 years' time, the trauma system will look different for elderly patients with frailty fractures, however sick they are and however in need of pre-hospital critical care. And, you know, and they should come to HDU and they should come to ICU, and we should do our best to help them survive with a good outcome. I'm just not sure that labeling the major trauma and squeezing them into a system that was designed for young patients to survive their multi-system injury necessarily gives them the best care. Thank you.
Thanks, Tom. I was relying on you to make those points. So that was perfect. And I think the other thing that what you sort of touched on in there is that, and I think it's nice to hear people using the terms more things like frailty and stuff more, because age in itself is such a poor discriminator. And you have the 65-year-old who's nursing home bound with multiple comorbidities, and you have the 65-year-old who can, you know, run a marathon better than any of us, but except for maybe Mike. So it's using just an age as a marker isn't sensitive for a lot of these factors. So I think that's the other thing to remember. So yeah, nice to hear the level of discussion and interest in this. Is there anybody else on the call who had any other questions or wanted to make any comments before we wrap this up? We'll share the recording around. Dave, go ahead.
Morning or afternoon, actually. Really interesting paper. Thanks for that. There's a few things I was kind of left thinking about with regards to how we dispatch with elderly fallers, because obviously it's a growing problem, and I think the solutions this is going to be with regards to technology and resourcing. One of the things I found really interesting in the paper is that you stated that you found one of the kind of two prime mechanisms was RTC and falls greater than 2 meters. And just one question in regards to that, with the falls greater than 2 meters, is that linked to more kind of falls down the stairs? And just trying to get really deep into that mechanism for it, because especially from an EOC point of view, we get these fallers coming down. And with that elderly generation, the falls down the stairs are always a little difficult ones, because they're either fine or they have that kind of gradual reduced GCS. So if we can get on top of that earlier, that will obviously be beneficial for the patient. The second thing that came to mind was resourcing. And if we can start working more jointly with our colleagues in the CHUB, because obviously elderly fallers is a big issue in the LAS. And Mike, I might be wrong, but I'm saying if you've got an elderly faller who's been on the floor greater than 1 hour, they get upgraded to a Red 2 response. So they have to have an ambulance in 8 minutes. Could there be a place to get CHUB clinicians more involved, start to triage these elderly fallers using Good Sam, asking more questions with regards to the mechanism, so we could be flagged up a bit earlier for potential HEMS dispatch? Just as a question to the group, what people's thoughts are on that.
So yeah, what I kind of gathered from the paper really that at the immediate dispatch was falls greater than 2 meters, and I kind of envisioned those as an unbroken fall, and then the crew request was the falls of less than 2 meters. As you know, David, with all these elderly fallers and long lives, really, we kind of really rely on the initial kind of AMPDS filtering out whether they did fall from standing or down the stairs or from a height, really. And yes, I think, you know, that would be a good idea to get the CHUB involved. But then I think really essentially with the ambulance service and the REAP level, for example, even at the moment being at REAP 4, we really rely on the actual clinicians getting there. But no, yeah, definitely worth a thought to get the CHUB involved. But I know that quite often they're extremely busy as it is, really. Yeah. Any other thoughts from anyone else?
I was just going to say, Dave, that's a good point. And just on your first one, so certainly from our point of view, we were kind of a little bit limited on what we collected from a data point of view on our sort of electronic PCRs. But certainly it would be interesting, isn't it? There's some research out there around using sort of conversational analysis on that initial call. What sort of words are being used by perhaps bystanders, grouping the words together, and perhaps something like that might be worth looking at just in terms of the groups of fallers themselves. But I think that the start point for that would have to be, you know, fallers as a, you know, every fall less than 2 meters that comes into the dispatch centre. But I'm not sure if there's any work out there, but that would be something that would be quite interesting to look at.
Thank you. Yeah.
Sure, go ahead.
No, I was just saying, I think it's one of those, it's a tricky thing, obviously, like Mike was saying, with the REAP level as well, that all services across the country are going to be particularly busy, especially winter pressures coming up. I do feel that I think what a potential solution is, and how we expand and develop our technology, our IT, our triage services, and how we can, nuance that, and especially when it comes to fallers, whether having like a separate algorithm for elderly fallers, like you mentioned before, Joanne, like actually looking at the kind of conversations used, the words, incorporating Good Sam into that as a potential solution. But it will, until we get that investment and more resources, it's going to be a tricky one to manage.
Thanks. Yeah, it's unfortunate. You're definitely breaching on the world of AI, Joe. And Rich Muswell did a great journal club a couple of years ago now, probably 3 years ago. Unfortunately, it was before we started recording these, thanks to COVID. So I don't have that one, but and his was on the use of a paper that's out there. If you haven't seen it, I can send it to you about. It was from actually LAS, looking at AI in informing dispatch and stuff, and using sort of word combination pairs and things for, I think they were looking at unresponsive patients and predicting cardiac arrest, but definitely something to think about in the future. Tom?
Yeah, I think it's interesting to think about how we can get as much information as possible from all the different bits of the control room that have eyes on these patients. I think it's probably also, particularly for our service, with sort of fairly short response times and wanting to focus in on the patients who have the greatest ability, the greatest benefit from immediate interventions, that I think, what am I trying to say? I think our service works at its best when we are getting activated to people promptly, and we're able to deliver immediate interventions that, that impact on their physiology, in London, with the advanced critical care practitioners and with a very mature trauma system, that patients are pretty close to. Some of the sort of softer interventions that we used to do in terms of sort of, supporting analgesia and supporting triage, I think are perhaps less needed from us as a HEM service. So I guess I find it slightly hard to work out what we would be doing to benefit an elderly patient who's fallen, who's been, who's at ground level on the floor, who's been on the floor for an hour, who's still conscious and breathing, and is 15 minutes by road from a major trauma centre. I'm not saying that those patients don't have clinical needs, but I'm not sure that it needs a doctor, paramedic, critical care team to meet those needs. And I guess we're always going to have to make sure that what we do is deliverable at the scale that we can work at. And I'm going to have to dive off for another meeting in a minute, I'm afraid, but Great discussion. Thank you.
Thanks, everyone. Yeah, I took Dave's comments to not necessarily about the Chubb and stuff, and you can always correct us offline, Dave, but it'd be around the idea of using more people looking at sort of calls that don't necessarily flag up as high acuity earlier on for those high acuity patients, to catch them, as opposed to looking for the patients that have been on the floor for a long time kind of thing, but I may be wrong. Anyways, I will have to end it there because it is time. Thanks, everybody. I'll post the recordings, and yeah, it's been a pleasure. Hopefully I'll be able to join future LAA journal clubs remotely, and wish you all the best in ongoing work with the research, and very excited by the stuff that's happening in London, in the UK, with the HEMS audit and research forum, and all the other things that are developing. So best of luck. Thanks, Mike, for a fantastic job, and I'll see you all again soon, hopefully. Bye-bye.
Thank you all.
Cheers. Thank you. Bye.